Next, we are going to look at congenital hemolytic anemias, which are classified under 3 categories. One is a defect of the red cell membrane. The classical example of this is hereditary spherocytosis, which I'll be discussing in detail. The second category is hemoglobinopathy, where the problem is in the hemoglobin or the globin chains especially. The characteristic examples, as you should be knowing about, are thalassemias. There are alpha and beta thalassemias. What I'll be discussing in detail is about beta thalassemias. Next is sickle cell anemias. These are classical examples of hemoglobinopathies. The third category is a disorder of red cell metabolism, metabolic activity, which is mediated by some important enzymes. And a very classical example of this is G6PD deficiency, which is glucose 6-phosphate dehydrogenase deficiency. We will be seeing all these disorders in detail subsequently. I'm starting with a discussion of hereditary spherocytosis first. The name is derived by the characteristic shape of the RBC, which is spherical. That's why it's called spherocytosis. We all know that it is an inherited disorder. In fact, most of the hemolytic disorders which we are going to discuss further are all inherited disorders. What is the mode of inheritance of hereditary spherocytosis? It is autosomal dominant. That is the most common mode of inheritance in 75% of cases. You can have remaining cases as autosomal recessive inherited forms as well as due to new or de novo mutations. Okay, so the other categories include autosomal recessive, which is rare, as well as the other rare form, which is de novo mutation, that is new mutation occurring in the child. Okay, but practically if you are asked to choose one option, choose autosomal dominant. What is the basic defect in hereditary spherocytosis? It is in the shape of the RBC, or what I am going to write as cytoskeleton defect. Okay, now basically remember this, there are so many proteins which contribute to the maintaining the shape of the RBC or maintaining to the cytoskeleton of the RBCs. A defect in any of those proteins can be associated with hereditary spherocytosis. Now, what are the common proteins which are defective? These include ankyrin, spectrin, and band 3. Now some important MCQs are there. Ankyrin is the most common defect, most common protein defect. This is an MCQ question. Spectrin, remember as S for S, spectrin is the most severe. So S for spectrin and S for severe. That is what you are going to remember. And band 3 defects are usually noted in adult patients with hereditary spherocytosis. So some case of hereditary spherocytosis manifest or start manifesting in the adult age group. Their band 3 defects are noted. These are usual one-liners which you should know about. Let us see what is the basic pathophysiology or problem in hereditary spherocytosis. I told you that there is a cytoskeletal defect resulting in the formation of spherical RBCs. Instead of the normal shape, they have become spherical. That is a basic problem. Now, this spherical RBC, the problem is decreased deformability. And this decreased deformability is a problem when it goes through the spleen microcirculation. That is a small capillaries of the spleen. When they go through that, they are not able to squeeze or not able to squeeze through or not able to pass through the capillaries in the spleen. That's what I'm going to write as not able to squeeze through splenic microcirculation. As a result of which they become trapped. They become trapped as well as engulfed by splenic macrophages. That is a basic problem leading to hemolysis in case of hereditary spherocytosis, where the abnormal spherical RBCs are trapped and lysed in the splenic microcirculation. Okay, now let us see what are the features of hereditary spherocytosis. Of course, like with any other hemolytic disorders, they will have anemia as well as jaundice. Please remember, jaundice is not present throughout the child's life. It is coming as intermittent or episodes in between. So intermittent jaundice is important. A very important side note to be remembered here is 50% of patients with hereditary spherocytosis even have jaundice starting from neonatal period. So neonatal jaundice is also one of the important manifestations that one should not forget in case of hereditary spherocytosis. And because spleen is the site of destruction or lysis of the RBCs, there is also enlargement of the spleen or splenomegaly, which is an important clinical examination finding that one should not miss. Okay, because this is an inherited disorder, most of the times you will get a family history of anemia or jaundice, as well as family history of splenectomy done for this splenomegaly in the family members. That is also an important history to be noted. So these are the characteristic clinical features that one should know about. Next is regarding the lab features. Lab features are characterized by the presence of spirocytes. This is the peripheral smear which is showing the spirocytes. Can you see all these densely stained RBCs, which are the spirocytes? Very characteristic of hereditary spherocytosis. Okay, why they are densely stained? Because of the shape which is spherical. Okay, and because of that density, there is also increase in MCHC. What is MCHC? It is mean corpuscular hemoglobin concentration. Okay, the next important feature in the lab findings is increase in osmotic fragility. Now this increased osmotic fragility is noted especially when you incubate the RBCs or the blood for 24 hours at 37 degree centigrade of temperature. That is when prominent increased osmotic fragility is noted, and this is an important question. And the name of this is called incubated osmotic fragility. That is also to be noted and can be asked in your exams. Okay. Finally, coming to the management of hereditary spherocytosis. All these patients require lifelong folic acid supplementation. This is to decrease the possibility of red cell hypoplasia. Please remember, continued hemolysis has more folic acid requirement basically for production of red cells. That is why we are giving folic acid supplementation as a lifelong treatment for these children. Okay. Next important treatment is splenectomy. Okay, splenectomy almost cures hereditary spherocytosis. It will normalize the RBC lifespan. Why? Because I told you spleen is the area where these RBCs are getting destroyed. So splenectomy eliminates that possibility. Obviously, anemia will also improve after splenectomy is done. There are certain important points that one should know regarding splenectomy in children with hereditary spherocytosis. First, splenectomy should be deferred until 5 years of age. Why this 5 years of age? Because of an increased risk of post-splenectomy infections. Okay. Please remember, spleen contains a lot of splenic macrophages which take care of encapsulated organisms. So what will happen? Post-splenectomy, these encapsulated organisms pose a threat of serious infections in the child. What are these encapsulated organisms causing infections? These include pneumococci, that is Streptococcus pneumoniae, H. influenza type B, Haemophilus influenza type B, and meningococci. That is why it is very important that children who are undergoing splenectomy should be vaccinated against all these 3 infections. Okay, and guidelines say that at least 2 weeks prior to splenectomy, all these vaccinations should be completed. That is an important point to be noted. Okay. And one more point to be noted is after splenectomy, these patients should receive penicillin prophylaxis as well in order to protect from these infections. And penicillin prophylaxis should be continued for 1 year after splenectomy. These are the guidelines and important points regarding splenectomy in hereditary spherocytosis. That is about the features and management of hereditary spherocytosis. We now move on to the category of next hemolytic disorders, which is hemoglobinopathies. There are two important examples. One is the sickle cell anemia, and the next one is the thalassemias. What I'll be discussing in this module is beta thalassemias. I'll start with sickle cell anemia. Okay, this is again an inherited disorder. The mode of inheritance is autosomal recessive. What is a basic defect in sickle cell anemia? It is in the beta globin chain, 6th position. That is a key word here. In 6th position of the beta globin chain, normally there is glutamic acid or glutamate. Okay, that is replaced by valine. That is what we famously remember as a mnemonic. What is that? Glutamate, which is G. Glutamate goes, G for G, glutamate or glutamic acid goes, and valine walks. V and W sound similar, so valine walks. So glutamate goes and valine walks. That is what is a basic defect in case of sickle cell anemia. And the usual reason for this is point mutations, commonly missense mutation occurring in the genes which are coding for the beta globin chains. This is the basic abnormality or the defect in case of sickle cell anemia. Now let us see what is the problem because of this sickle cell anemia. Okay. Now let us look at what is the pathophysiology of sickle cell anemia. I told you there is some alteration in the amino acids, because of which the shape of the globin chain itself is changed, and this hemoglobin is what we will designate as HbS. Remember, the normal adult hemoglobin is designated as HbA. These children have more of HbS. S here refers to the sickle, okay, sickle, which is the characteristic shape of the RBCs. This is how the sickle looks like, okay, right? So that is why it is called as a sickled RBCs or HbS, okay. Now remember, the main problem in case of sickle cell anemia is that when these children are exposed to hypoxia, dehydration, acidosis, what happens is there is an increased rate of sickling of the RBCs. So what happens? RBCs keep changing the shape to a sickled shape. And these sickled RBCs, as they pass through the blood vessels, they will cause blockage. Okay, this is the main problem because of the sickling. You can see in this picture, which is describing the changes in sickle cell anemia. This is what is happening normally. When you have a normal hemoglobin, the cells will squeeze through the blood vessels without any problem. However, in case of sickle cell disease or sickle cell anemia, what is going to happen? The shape of the RBC, can you notice that? The shape is sickled like this. And this sickled RBCs, they are going to block the circulation. That is a main problem in case of sickle cell anemia. I hope you're able to follow this. Now let us look at what are the clinical features arising because of this pathophysiology. Okay, just like any other hemolytic anemia, these children also can have icterus, that is jaundice, pallor due to anemia, and mild splenomegaly is noted in most cases. Second, they also have increased risk of recurrent febrile episodes due to multiple infection. Now coming to more peculiar features of sickle cell anemia, which are very important because they can be asked as case scenario based questions. There are different types of crisis occurring in sickle cell anemia. Crisis generally refers to sudden manifestations, okay? And one of that important crisis here is vaso-occlusive crisis. Okay, as I said, lot of sickled RBCs, they will block one blood vessels, and that is what is called vaso-occlusive crisis. The characteristic manifestation of vaso-occlusive crisis is the presence of pain, and that is more related to bones, bony pain. Okay, the commonly affected bones in this particular condition are the long bones like the femur and tibia. And another important manifestation related to bony pain is occurring in infants, that is young children. They ask you this question commonly. What is the first manifestation of sickle cell anemia in young children? It is dactylitis, which is nothing but painful swelling of the hands and feet. Very, very characteristic and an important MCQ question, so do make a note of it. The next set of manifestation related to vaso-occlusive crisis may occur in the kidney. In kidney, there is renal papillary necrosis. Renal papillary necrosis. And what is the manifestation because of this? The kidney loses the ability to concentrate urine, okay, inability to concentrate urine because of papillary necrosis, and this results in isostenuria. Isostenuria refers to fixed specific gravity in the sense that the osmolarity of the urine is same as that of the plasma, and this is attributed to loss of urine concentrating ability of the kidney. Third is spleen. Because of repeated vaso-occlusive crisis, spleen can undergo repeated infarctions. What happened? Because of repeated infarction, the size of the spleen keeps on decreasing, and at one point of time, no spleen tissue is left. This is what we call it as autosplenectomy. Autosplenectomy. And please remember, autosplenectomy usually happens by the age of 6 years. That is why children with sickle cell disease after 6 years do not usually have a palpable spleen. So what happened? They have asplenia. That is the point to be noted. Okay. Next is regarding the central nervous system manifestation. It is in the form of occlusion of cerebral blood vessels resulting in stroke. And finally is a very important and a severe manifestation of vaso-occlusive crisis, which is what we call it as acute chest syndrome related to vaso-occlusion of the pulmonary blood vessels. This is a condition which resembles just like sudden pneumonia, in the sense the child would have fever, cough, breathing difficulty as well as fast breathing or tachypnea. Along with that, hypoxemia. If you take the X-ray, that is a chest X-ray, there would be presence of new infiltrates on the chest X-ray. New infiltrates. Remember, this is an emergency. These children have to be admitted and treated just like pneumonia. You have to provide oxygen support to these children. Number 1. Number 2, IV fluids. Number 3, bronchodilators. And number 4, don't forget, these children requires broad spectrum antibiotics. Okay, usually a combination of third generation cephalosporin, and along with that you have to add macrolide antibiotics also, like azithromycin or erythromycin. This is because infections with atypical organisms like mycoplasma and chlamydia is equally common in a setting of acute chest syndrome. So that is why it is recommended that for atypical organism, macrolide is a usual effective antibiotic. So always remember, when you're treating acute chest syndrome, make sure you combine cephalosporin, that is third generation cephalosporins, along with macrolide antibiotics. These are the typical examples of vaso-occlusive crisis. The next type of crisis is sequestration crisis. which is basically due to sickled RBCs which are blocking the venous outflow of the spleen. So what happened? They block the veins of which are going out from the spleen. Venous outflow of the spleen is getting blocked. So what happened? The blood is retained inside the spleen itself, or engorgement of the spleen occurs. Engorgement of the spleen occurs. So obviously what will happen to the size of the spleen? There is a sudden increase in the size of the spleen. And also spleen is one of the site of destruction of the RBCs as well. So what happened? Whenever there is more amount of blood staying inside the spleen, there will be more decline in the hemoglobin also. So there is a decline in the hemoglobin to more than 2 grams. For example, the baseline hemoglobin in that patient was 9 grams per deciliter. It would decrease to less than or equal to 7 grams per deciliter. That is what is the decline in hemoglobin I was talking about. This is the sequestration crisis, which is the next type of crisis which can occur. The third crisis is aplastic crisis. Remember, aplastic crisis is a condition characterized by sudden decline in all the cell counts or pancytopenia. And this aplastic crisis is usually precipitated by an infection. The commonest infection is parvovirus B19 infection. Parvovirus B19 infection, which has been asked as an MCQ question previously. Okay, that is a third type of crisis which can be encountered. So remember 3 important types of crisis, namely vaso-occlusive, sequestration and aplastic crisis as characteristic features of sickle cell anemia. Now coming to the lab features of sickle cell anemia, obviously when you look at the peripheral smear, you will see evidence in the form of sickled RBCs. If you are not able to see the sickled RBCs, still your possibility of sickle cell is high, then you can do a test called as a sickling test, which is done by some chemicals like 2% sodium metabisulfite. These chemical agents increase the chance of sickling. So give these agents and then again look under microscopy. You will find evidence of sickled RBCs. Third, very, very important investigation is hemoglobin electrophoresis, which will help you to find out the hemoglobin S very correctly. Okay. Now, very, very important question. What is a final confirmatory test or the gold standard test? If we ask that as a question for all hemoglobinopathies, please remember the gold standard test is HPLC. What is that? It is high performance liquid chromatography. This is the gold standard or the best diagnostic test in case of all hemoglobinopathies, not only sickle cell anemia, even the next hemoglobinopathy we are going to see, thalassemia. For that also, the gold standard test is HPLC. Now, coming to what is the management of sickle cell anemia. Please remember that, as I said, these patients are prone for crisis due to sickling of RBCs. And in crisis, the main manifestation I told you is pain. Okay, so pain has to be adequately managed. Most of the crises are precipitated by dehydration or hypoxia. So that is why management with IV fluid and oxygen is also equally important. So if there is a question, what is a mainstay in the management? It is hydration and analgesia at the times of crisis. Very, very important. Even they require stronger analgesics like narcotic analgesics also for control of pain. That is the first part of management. Second thing is something called red cell transfusion, basically blood transfusions. Now, this is to improve the oxygen carrying capacity, thereby decreasing the severity of the episodes. And it is not indicated in all type of crisis. It is usually indicated in aplastic crisis and sequestration crisis. because that is the time you'll have a sudden decline in the hemoglobin levels. Okay, that is why a plastic and sequestration crisis, it is very helpful. A third important aspect of management is exchange transfusion, where what you do, you exchange the patient's blood with the fresh blood. Why? Patient's blood contain a lot of sickled RBCs. They are replaced by normal RBCs. That is why it is called exchanging the patient's sickled RBCs with the fresh RBCs. So that is why the name is exchange transfusion. Okay. Now exchange transfusion again is not indicated in all cases. In situations like stroke, because of vaso-occlusion in the cerebral blood vessels, stroke can occur. There it is very helpful. And number 2 condition where it is helpful is acute chest syndromes. And there can be a question, what is the goal of exchange transfusion? The goal of exchange transfusion is when you replace the patient's red cell with the fresh red cell, you are decreasing the concentration of HbS, right? So the goal is to decrease the HbS to less than 30%. Don't forget, this is the goal in case of exchange transfusion. There are some medications which can also be helpful in the management. These include some drugs. Number 1 is hydroxyurea, which is usually started in children more than 9 months of age. And the role of hydroxyurea is that it increases the levels of HbF in the body. What is the role of this HbF? This HbF is supposed to decrease the episodes of sickling, thereby decreases the pain or the episodes of crisis, decreases the rates of hospitalization, as well as decreases the requirement of transfusion. Decrease transfusion requirements. That is how hydroxyurea is beneficial in a child with sickle cell anemia. Another important molecule which is recently approved by FDA is L-glutamine. L-glutamine. L-glutamine is also found to decrease the incidence of vaso-occlusive crisis. Okay, so these 2 medications, namely hydroxyurea and L-glutamine, are potential MCQs for the upcoming exams, which you should know about. Okay, finally, regarding the best management of a patient with sickle cell anemia, what is that? It is nothing other than hematopoietic stem cell transplantation. This is the curative treatment option for a patient with sickle cell anemia. Okay, so those are the salient points about sickle cell anemia that you should know about. Next hemoglobinopathy I am going to discuss about is thalassemia. As we all know, thalassemia is a condition characterized by decrease in the production or synthesis of one or more hemoglobin polypeptide chain. Basically, I am talking about the globin chains. We all know that there are 2 alpha and 2 beta globin chains. So thalassemias can either be alpha thalassemias or beta thalassemia. In this particular module, I am going to discuss about beta thalassemias. Please remember, beta thalassemias occur due to a problem in the production of beta globin chains. And beta globin chains are coded by 2 genes which are located on chromosome number 11. Okay, so any problem in these 2 genes can be associated with beta thalassemia. Usually it occurs due to point mutation. Point mutation. And there can be a question, what is the most common type of point mutation occurring in this condition? It is a splicing mutation. Very important. It's a splicing mutation. Okay, right. Because 2 genes are controlling, there are many possibilities in beta thalassemia, or in other words, you can have a wide spectrum of beta thalassemia. First is about thalassemia trait, which is supposed to be the mildest form of beta thalassemia, wherein the patient can have mild degrees of anemia. Sometimes they are asymptomatic also. And this condition is characterized by increased levels of hemoglobin A2, which makes up to around 8% of total hemoglobin. And they will also have slight increase in hemoglobin F, which is around 5% of total hemoglobin. And this increase in A2 is one of the defining features and commonly asked as MCQ questions related to thalassemia trait. Next we have intermedia. Thalassemia intermedia is characterized by anemia of varying grades, accompanied with jaundice and splenomegaly. Okay, and in this particular variety, transfusions, that is blood transfusions, may or may not be required. That is the point to be required. That is the point to be noted. And please remember, even if they require transfusion, it's very infrequent transfusion. That is a point to be noted again. That is about thalassemia intermedia. Now, coming to the important variety where I am going to discuss in detail, which is thalassemia major. This is a condition which is transfusion dependent. Okay, these patients are practically dependent on blood transfusions for their life. So this is a transfusion dependent anemia, and obviously the most severe form of beta thalassemia spectrum. The other name for this beta thalassemia major is called as a Cooley's anemia or Mediterranean anemia. Okay, please remember the word thalassemia. Thalassa refers to sea. Okay, and something like referring to the Mediterranean Sea. Okay, and emia is something which is related to blood. Related to blood. That is why it gets the name as Mediterranean anemia. Okay, right. Now let us see what is the pathophysiology of beta thalassemia major. As I told you, this condition is characterized by absent production of beta globin chain. So absence of beta globin chains, because of which there is a relative increase or relative excess of alpha chains. So what happens is that in that hemoglobin, there is only alpha chains. There is no beta chain at all. And what happens? This excess alpha chains are insoluble substances. So what happens? They will accumulate in the erythroid precursors itself, starting in the bone marrow itself. So in the stage of erythroblast itself, they will start accumulating. What accumulates? Yes, the insoluble alpha chain starts accumulating. Now, this insoluble alpha chains, they promote apoptosis of the erythroblast. So what happens? The erythroblast will not even be converted into the subsequent stages like the reticulocyte forms or the RBC forms. Nothing will be produced. At the stage of erythroblast itself, there is apoptosis. So practically, no erythroid cell is coming out of the bone marrow. Are you able to follow this, right? This is what we call it as ineffective erythropoiesis. Ineffective erythropoiesis. So practically, bone marrow is not producing or releasing any erythroid cell. Okay? And due to this ineffective erythropoiesis, there is anemia. Okay? And to compensate for that anemia, the patient will require regular blood transfusions. That is why I was telling you that this condition is a transfusion dependent anemia. Okay, and please remember, once you give regular blood transfusions to the patient, okay, it can predispose to iron overload. Very, very important point. And most of the times, this is a problem maker. Okay, iron can accumulate in different parts of the body, and the most important area affected is the heart. And when there is heart involvement, it can even lead on to CCF, congestive cardiac failure, which is the cause of death in these children. It is an important MCQ question. So that is why in the later part of this discussion, I'll be telling you about management of iron overload, which is very important to decrease the morbidity and mortality. Okay, right. So as I was telling you, the reason for anemia is ineffective erythropoiesis. Because of ineffective erythropoiesis, there is also compensation. How? In the form of extramedullary hematopoiesis. Extramedullary hematopoiesis, wherein you will have the bones which normally don't take part in hematopoiesis also now will start taking part in hematopoiesis. Next, you have some organs which are usually not involved in erythropoiesis now getting involved in hematopoiesis. That is a form of compensation for ineffective erythropoiesis. For example, if the bones are going to be affected, especially the facial bones are going to be affected, you will have characteristic problems like this, what you see in this picture. You can notice that because the facial bones have started to take part in erythropoiesis, this child is having characteristic manifestation. For example, number 1, you can see that the forehead is very broad or there is a frontal bossing because of the expansion of the bone marrow as it is taking part in hematopoiesis. Number 1. Number 2, there is prominence of the cheeks due to the maxillary bone expansion due to involvement of the maxilla. Third is there is dental malocclusion, again due to expansion of the jaw bones. And this characteristic appearance is what we call it as the chipmunk facies. Okay, right? This is the name given for thalassemia facies. Next is, if you look at the X-ray of the skull, you can see that there is expansion of the skull. Can you notice that? Why I am saying expansion? Because you can see that there is increased markings in all these areas which tell you that there is an expansion of the spaces in the skull, because they are also starting to take part in hematopoiesis. And this expansion of the skull is what we call it as hair on end appearance or crooked appearance. Okay, so these important findings you should never miss. They are commonly asked in the MCQ exams. One is the chipmunk facies, next is the hair on end appearance, and third one is a crooked appearance. Never to be forgotten as classical features of beta thalassemia major. As a part of extramedullary hematopoiesis, some of the organs also will start taking part in hematopoiesis, especially the liver and spleen. So we will have hepatosplenomegaly as a manifestation. So this slide summarizes the pathophysiology as well as the major clinical features noted in case of beta thalassemia major. Now we are going to look at the management of beta thalassemia major. As I have said before, this is a transfusion dependent anemia, so regular blood transfusion are required for this child. Usually is given at the intervals of 3 to 4 weeks. And please remember, the goal of us to give this regular blood transfusion is to maintain a pre-transfusion hemoglobin, very important word, pre-transfusion hemoglobin level of 9.5 to 10.5 grams per deciliter. Okay, what is this pre-transfusion? It is nothing but that nadir or the baseline level of hemoglobin to be maintained in the range of 9.5 to 10.5. Why this cutoff is taken 9.5 to 10.5? This is because it will ensure optimum growth of the child. Very important. One is optimum growth of the child. Second is that if you maintain sufficient amount of hemoglobin, that extramedullary hematopoiesis will not occur. Or in other words, abnormal facial appearances or the deformities will not occur. So it will decrease the occurrence or decrease the severity of deformities in the child. These are the two main advantages if you maintain the hemoglobin at a stable level of 9.5 to 10.5 grams per deciliter. And to maintain this, we are giving regular blood transfusion every 3 to 4 weeks. What is the problem of this regular blood transfusion? As I told you before, is iron overload. Very, very important. An iron overload usually occurs after 1 year. Okay, after 1 year of starting transfusion treatment or after 1 year of transfusion therapy. That is an important point to be noted. And there is an important question. How to know that there is iron overload in the body? Or in other words, they can ask you what is the best way of assessing iron overload in the body. For this, the answer is going to be assessment of liver, preferred number 1. Number 2, heart by MRI. Very, very important point, by MRI. Okay, right. And usually the techniques which are useful are R2 bar R2 asterisk, and for heart it is a T2 weighted MRI. These are the usual MRI sequences which are preferred for estimating the iron overload in case of transfusion dependent thalassemias. Okay, right. So now the next question obviously is to how to tackle this iron overload, because I said if you don't check iron overload, child can develop problems. Even the heart affected can go in for cardiac failure, and that can result in death also. Okay, so very, very important part of management is iron chelation. Okay, as I said, iron overload usually occurs after 1 year of transfusion therapy. This roughly corresponds to ferritin levels of more than 1000 nanograms per ml. So that is why we keep following the ferritin levels in a child once the blood transfusion is started. And once the ferritin level reaches more than 1000 or more than 1 year has been over after starting the transfusion therapy, we will start iron chelation. There are different iron chelators which are available. I'll write down the names of them. One is deferoxamine. Another one is deferazerox. And the third one is deferiprone. Please remember, deferoxamine is a parenteral formulation which is usually given by subcutaneous or intravenous route, whereas deferazerox and deferiprone are oral iron chelating agents. Please remember, they require this chelating agent for a long period of time. So nowadays, oral chelating agents are preferred, obviously because of the parenteral administration of deferoxamine. Okay, so now oral chelators are being used commonly, and the usual agent which is more effective in decreasing the organ damage is deferazerox. That is a commonly used iron chelating agent in the management of beta thalassemia major. So don't forget, in beta thalassemia management, both blood transfusion as well as iron chelation have a major role. Now, if there is a question asked like, what is the only curative treatment for beta thalassemia major? What should be the answer? It is HSCT, which is hematopoietic stem cell transplantation. HSCT offers more than 90% cure rate. But only thing is, it should be done prior to liver involvement. Very important. For example, if there is hepatic fibrosis, okay, and after that, if hematopoietic stem cell transplantation is done, outcomes are not good. But before liver becomes damaged, there is 90% or more than 90% cure rate. That should be remembered, and that is the only curative treatment option for a child with beta thalassemia major. Okay. So with that, I completed that hemoglobinopathies, which is a second category of congenital hemolytic disorders. The last category of congenital hemolytic disorders is a defect in red cell metabolism. Now, talking about red cell metabolism, you should know certain basic facts and certain basic metabolic pathways. First of all, remember, RBCs, they lack mitochondria. Okay. Because of which they depend only on anaerobic metabolism of glucose. Anaerobic metabolism of glucose. Okay. For ATP production. Okay. This is a basic fact which all of us know. Now, one of the important metabolic pathways operating in this regard is HMP shunt, or the hexose monophosphate shunt. And you should know that the rate limiting enzyme of this particular metabolic pathway is G6PD, which is glucose 6-phosphate dehydrogenase. Let us understand what is the role of G6PD. It provides NADPH as well as glutathione. Remember, NADPH is required for generation of glutathione. Now this glutathione is very, very important because it protects the RBCs from oxidative stress or oxidative damage. That is an important point. Now we are going to look at a condition called as G6PD deficiency, which is an inherited condition. Okay, G6PD deficiency, which is an inherited condition associated with hemolysis. How exactly? Whenever there is low G6PD, obviously there will be low levels of glutathione. So what will happen? There won't be any protection of RBC from the oxidative stress. So what happen? RBC will be prone for oxidative stress. And whenever oxidative stress happens, it would result in hemolysis of the RBCs. Very simple. That is how G6PD deficiency will be associated with a hemolytic disorder. Let us see in detail about G6PD deficiency. It is again an inherited disorder, but here the mode of inheritance is X-linked recessive. Very, very important point. So males are going to be affected by this condition. Next point to be noted, it is more frequent in certain group of population, African, Asian and Mediterranean population. Okay, so that is where it is noted. Okay, so ethnicity is also a feature of G6PD deficiency. What are the characteristic clinical features? Remember that these patients will have hemolysis as I have described, but this is not a constant hemolysis. It is only intermittent episodic hemolysis. So what are the factors which can precipitate hemolysis in these children? One, or the precipitating factors would include: 1. Infections. Number 2, consumption of some food substances, and very important in this regard is fava beans. This has been asked as an exam question. Which food substance consumption is associated with risk of hemolysis in G6PD deficiency patients? It is fava beans, number 2. And number 3 is exposure to certain drugs. Very important. This is also a favorite question. What are the drugs which are associated? Number 1 is Primaquine, anti-malarial agent. Number 2, sulfonamides, especially sulfamethoxazole, very important group of medication. Third is phenazopyridine, which is otherwise called as pyridium, that is also associated. Next is nitrofurantoin, and one more is nalidixic acid. These are all important medications which can be associated, which can trigger hemolysis in G6PD deficient patient. So don't forget, they have episodic hemolysis. Coming to the lab features of G6PD deficiency, please remember two important findings which you can notice in the peripheral smear. One is Heinz bodies, and number 2 is the bite cells. Let us see how they are going to occur. Very simple. I told you G6PD deficiency results in oxidant stress or a damage to the RBCs. And because of the oxidative stress or the oxidant stress, there is conversion of hemoglobin into methemoglobin, which becomes denatured. It undergoes denaturation. Upon denaturation, it forms intracellular inclusions in the RBC itself. And these intracellular inclusions is what you see as Heinz bodies. That is a point to be noted. It is a denatured hemoglobin found as intracellular inclusions in RBC. That is what is Heinz body. Now remember, when these abnormal RBCs, they pass through the spleen, what happens? There are macrophages in the spleen, right? Those splenic macrophages will take a chunk of that intracellular inclusion or sort of bite that RBC and take away those intracellular inclusion. So what happens? The RBC will appear something like this. What is happening? That bitten area is something which is taken up by the splenic macrophages. Very simple. So that explains the two characteristic findings in the peripheral smear. One is the Heinz bodies and other one is the bite cells. Now talking about the management, please remember that most episodes of hemolysis in G6PD are self-limiting. So no specific management is required. Only thing to be noted is they should avoid all the precipitating factors. I've already told the precipitating factors like infections. So early diagnosis and correct treatment of infection is recommended, number 1. Number 2, avoid consuming fava beans because they can trigger the episodes. Number 3, limit exposure to all the drugs which I have mentioned like this nalidixic acid, nitrofurantoin, sulfonamides because they also trigger the episodes of hemolysis. Generally for G6PD deficiency, the outcome is good because again repeating the fact that most episodes are self-limiting. So that is about the defects in the RBC metabolism. With that, we have completed the hemolytic disorder and that concludes the module of anemia in children.